So one of the other historically immune-sensitive cancers is kidney cancer. And it seems as if whenever you get a drug, an immunotherapy strategy that looks like it's working in melanoma, it works in kidney cancer. And in some ways that's been to the detriment of both malignancies and to the field because everybody's assumed that these are outlier diseases, right?
Right.
But certainly there has been exciting work in kidney cancer as well, and perhaps you'd like to share some of that with us.
So, I mean, kidney cancer as opposed to urothelial cancer is straightforward single agent activity. It may be that these compounds get at least initially developed as single agents. Kidney cancer is more complicated, mostly because of the therapeutic paradigm, right? So we're 7, 8, 9 years into the targeted therapy era. We've reached the plateau. We clearly have anti-tumor activity. People clearly live longer. Toxicity of those agents are substantial. So, and unlike perhaps even prostate cancer, where you've not been able to develop multiple drugs in the same class, kidney cancer has multiple tyrosine kinase inhibitors and a couple of TOR inhibitors. We don't really optimally know which one of those drugs to develop. So the question then becomes, as you bring in new immunomodulatory therapy, which has perhaps longer time to activity, and you're looking at PFS endpoints, and you're in a milieu where there's first and second and third line therapy, the question is, how do you understand what you're doing? So we're now in an environment where there are head-to-head trials of a PD-1 versus a second line TOR inhibitor, phase 3 trial, important study. It's not clear that these agents as a single agent in the milieu is going to have enough activity to see it to justify a registration. So at the same time, all of the combinatorial therapies of the TKIs, the bevacizumab, all of these things are now online, including IPI. So the question is, most of those trials are randomized phase 2. You're going to get signals. But the ability to then go forward and get a uniform trial so that you can see hard endpoints, and again, almost all drug approvals in the renal space have been PFS approvals, because can you actually see an overall survival advantage in any of these trials? Are you going to be able to get the signal to noise ratio? This is going to be very complicated, perhaps even more complicated than melanoma, because melanoma started with a sort of a different pace and trajectory of new drug development. We're now in a moderately mature environment. So I think that's going to be the challenge for us. It's not that these drugs don't work. They clearly work. The question is, do they work well enough as a single agent? Are there going to be more optimal combinations? And look, we know that there's theoretical rationale to take a TKI with its Treg impact and then use another immunomodulatory therapy. But it's more, we have this, so we add this at this juncture.
So I see this as the place where combinatorial checkpoint inhibition or combinatorial therapy may be able to show a benefit, since everybody sees so much therapy, so much sequential therapy, right, that if you are giving a combinatorial and the other arm is never being able to see it, and seeing every other drug that exists, you don't have the argument that we have in melanoma. Well, they went on to something else that they couldn't get, and that affected survival. Everybody sees everything. It will take longer, but we may be able to know more.
Perhaps. But it's going to, end of the line strategy is challenging, because as you know, if you're developing this in Western Europe and the US, there's a different how many therapies, as recent TKIs have failed because they studied them in an environment where standard therapy was not available. They didn't provide crossover, and a secondary endpoint was detrimental to the development of the compound.
I'm going to challenge both of you on something on the content of this conversation, because in my view, the difference between the use of TKIs, targeted therapies, or chemotherapy that prolongs progression-free survival and creates an increased response rate, but not necessarily has a major impact on overall survival, would, in my view, be going in a different sense as an evolutionary change in management. And I think what we're talking about with some of these immunotherapies are revolutionary changes, where the ultimate impact may be less about what proportion of people benefit, but how well the people who benefit actually do benefit. So that if you have 20% of the patient population you're treating with one of these drugs, these immunotherapy drugs, having a 4-year progression-free survival, or maybe getting cured, that's better than a drug that has a 60% response rate for 30 seconds. And which is kind of where we've been thinking about this as oncologists and drug developers for a long time. Now the challenge, and this is not necessarily for what we do in the practice of our craft, but rather in the art of getting a drug developed, is how do you actually develop a registrational strategy for a drug that isn't going to work very often, but boy, when it works, does it work well? And so how are you going to do that?
Well, I mean, you can look at the strategy that's just been undertaken. You have a phase 3 trial comparing an oral TOR inhibitor approved in the second line compared to a PD-1 with a PFS endpoint. And the reality is, if the trial's large enough, and if we're fortunate enough, you may see a signal in that kind of head-to-head comparison. I would argue that's actually the way we're going to see it, because the problem with combinatorial trials is that it's hard to believe that these are truly synergistic therapies. It's more that we don't know.
There's data about VEGF inhibition and its effects in the immune system. And Odie is presented, it's melanoma data.
But sometimes, again, many of us have been doing this for a long time. The anticipation of seeing synergy is a bit much for me to hope. It's always easy to see a home run. The problem here is I think that in kidney cancer, it's going to be complicated to be able to do the kind of studies that unequivocally provide the benefit that we talked about before, because again, I don't think there's any question. We don't need an evolutionary development here. We need to replace some of the therapies that we're using. The toxicities of the agents we're combining with are no less toxic because we combine them. They may be tolerable, but that's still a challenge. You can't give these drugs for prolonged periods of time.
Let me ask you, in renal cell carcinoma, IL-2, high-dose IL-2 has been a standard that somehow has been replaced because of the ease of giving TKIs. Where does high-dose IL-2 stand in its ability to be replaced by these checkpoint inhibitors, or in its ability to be the comparator for these checkpoint inhibitors? Can we do a trial
that's a great question.
comparing IL-2 to these checkpoint inhibitors?
So I think the answer is no, because of the toxicity profile. But at this meeting, actually, there is a registry of high-dose IL-2 being reported that appears to have even a better outcome than our historical understanding of high-dose IL-2. I think, if you talk to kidney cancer docs, do we still use high-dose IL-2 for selected patients? Absolutely. Why? Because it's still the only therapy that has the potential, albeit small numbers, but as you point out, big impact, right? So does it have the potential to replace that? Perhaps. Perhaps in exactly the same setting that a checkpoint inhibitor might be a single agent that controlled disease for a long period of time with acceptable toxicity, and to be applied in a larger group of patients, because we see patients who might be high-dose IL-2 appropriate based on what they look like, but their physiology isn't appropriate, et cetera. So I don't know we can do a randomized trial, but I don't think you necessarily have to.
So this gets back